Good afternoon, and welcome back. I'm Deb Schrag. I'm a population scientist at Dana-Farber, and really inspired by the terrific talks we heard this morning. I think we're going to shift gears a little bit right now and talk about delivering on all this promise of amazing prevention potential. I'm delighted to introduce our keynote speaker this afternoon, Dr. Sue Curry. Dr. Sue Curry is Provost at the University of Iowa, where she previously has served as the Dean of their College of Public Health, among many other leadership roles. Also previously at Group Health at the University of Washington in Seattle. Among many accolades, she is a member of the National Academy of Medicine and has really been a thought leader in the prevention space. In particular, she leads the U.S. Preventative Services Task Force, and as many of you know, that body is charged with formulating recommendations that are then disseminated to clinicians and healthcare providers and patients themselves across the country to really help us think about what prevention strategies are evidence-based and what actions we need to take. So I think we're in for a provocative and interesting talk, and we're delighted to welcome you. Thank you.
Great, thank you so much. I apparently forgot the name of my talk and I put potential instead of possibility in the title slide. But I'm really delighted to have the opportunity to participate in this symposium, and I want to say how humbling it has been to hear about the amazing work being done by our colleagues who've presented thus far. The vision, the commitment, and the certain success of this new center is inspiring. My remarks are offered in the context of advice and perspectives from someone who has directed centers and institutes in academic and healthcare settings. I've been working in cancer prevention for some 40 years. I know I started very young. Beginning with my doctoral work in tobacco cessation to joining one of the very first cancer prevention research units at the Fred Hutchinson Cancer Research Center. Now, as scientists, educators, advocates, and public servants, we are always laser-focused on fulfilling the potential for cancer prevention. Realistically, we are not going to prevent all cancers. The potential will change over time in terms of populations, types of cancers, and so forth. So before I start, let me dispense with my disclosures. I have no financial or other conflicts to report. As mentioned in the introduction, I currently serve as the chair of the U.S. Preventive Services Task Force, and so I would just want to note that this presentation reflects my individual views and does not represent the views or recommendations of the task force. And so, to begin. Now, by virtue of its existing talent, the Zoo Family Center for Global Cancer Prevention comes out of the box as a recognized leader in this critical area. As is evident today, the center is and will be a convener of people from across the country and the globe, a place that will attract scientists, practitioners, advocates, and trainees who have a passion for fulfilling the potential for global cancer prevention. My remarks are offered in the spirit of ensuring that the work of this center really makes a difference, and that requires attention to some foundational issues. First, it's important for us to understand what we mean by global cancer prevention. Our University of Iowa president will tell you that I'm the person in the room when everyone is swooning over study abroad as the panacea for improving student outcomes, that I'm always the one saying that we should be focusing on global and not international. And that's because global includes the world, and the world includes the United States. Second, I resonated to what is essentially, or what I was able to see, there was a more detailed one today, vision statement or mission statement of the Zoo Family Center for Global Cancer Prevention in terms of the intersection of education, research, policy, and most important, to the center being motivated by the belief that all populations worldwide should benefit from state-of-the-art cancer prevention strategies. I want to acknowledge a few key sources for my remarks that were published by the National Academies: a consensus study from 2007 on cancer control opportunities in low and middle income countries, a summary from a 2016 workshop on cancer prevention and early detection from a series of workshops on cancer care in low resource areas, and a consensus study from 2017 on global health and the future role of the United States. From the lens of advice and perspectives, I thought about what matters in fulfilling the potential for global cancer prevention. Now, as an aside, I can tell you that one thing that appears to matter in clip art is gender. I couldn't find anything that showed a woman, so there I am, thinking. What I thought of was disparities matter. Evidence matters. Context matters. Conceptual clarity matters. Collaboration and cross-fertilization matters. Public-private partnerships matter. And after listening to the talks this morning, I want to add another thought bubble, and that is ethics matter. And I was both exhilarated and petrified by some of what I heard coming down the pike in terms of passive monitoring and so on and so forth. And we've got to have our ethics front and center before we release some of these innovations. Now, I don't have time to do justice to all of these, so I'm just going to focus primarily on disparities and on evidence. But what I found as I addressed these is reflected in a John Muir quote: "When you try to pick out anything by itself, we find it hitched to everything else in the universe." And so these other considerations will be pulled forward as we go. So let's start with global cancer disparities. And just a few sound bites. Some of this is repetitive, but I don't think you can repeat this too often. Cancer cases are increasing worldwide. There were over 18.1 million in 2018, and that's projected to rise to 22. For some reason, I need my reading glasses, but I think it says 22.2 million by 2030. Cancer now kills more people worldwide than malaria, tuberculosis, and HIV combined. A majority of the cancer burden is in low and middle income countries. 30% of cancer deaths globally are due to preventable risk factors: behavioral, environmental, and pathogen exposures. And I was struck in the wonderful talk on Barrett's esophageal cancer that, what are the risk factors? Obesity, smoking, and poor diet. If we could make it as easy for people to eat healthy, to be active in their environments, and we got rid of tobacco, we might not need to be putting sponges down people's throats. But we're not there yet. The types of cancers that contribute to this scourge are not uniform across the globe. Prevalent cancers vary by Human Development Index. As shown here, high HDI countries, most prevalent cancers are breast, lung, colorectal, and prostate. Middle HDI are esophagus, stomach, and liver, and low HDI is cervical. Global cancer disparities include the US. There are parts of our country where rates of mortality from preventable cancers mirror those in low and middle income countries. Now, a recent paper in JAMA examined cancer disparities in the US by county. The overall conclusion shown here is that there are wide gaps in cancer death rates between low and medium and high income counties. Future studies are needed to assess whether targeting the possible mediators might ameliorate the substantial socioeconomic cancer disparities. In this careful analysis, we have the convergence of evidence, conceptual clarity, and context. Here's the surveillance data evidence in a figure from the paper, and the fine print and details are not critical, but I'm just going to highlight the take-home points. The heat map in the upper left shows cancer deaths per 100,000 by all US counties. Red is bad, dark blue is good. I am not making a political statement. As you can see, there are substantial differences and disparities in the US. We've got clusters of blue and clusters of red counties and so forth. Now, if we move to the heat map in the top right of this figure, it shows the distribution of scores on a disparity index created by the researchers, and I'm going to say more on that in just a moment. But it was created to represent the geographic spread of key factors that may act as mediators of income-related disparities in cancer death rates by county. And as you can see, the heat maps are almost identical. And that suggests a strong association between factors believed to be associated with health disparities and cancer mortality. Now, the authors recreated the heat maps, only this time they show the income-adjusted annual cancer death rate in each county for the lowest income quartile of counties in the US. The map on the bottom left shows cancer deaths per 100,000, and the map on the right shows the disparity index score ranges for that subgroup. Context matters, and this is reflected in the disparities risk index used in this paper. The index is complex, and the details aren't as important as the recognition in creating the index that context is multidimensional. Here are the domains, and these domains have multiple measures, and they're pulled from county-level data. And these are what was used to define the disparity index in the analysis. Now, what's interesting is they're very consistent with the social ecological framework, which is a key framework in cancer prevention and behavioral science disciplines. Remember that this index describes a county, its aggregate data, that includes consideration of socioeconomic factors, clinical care, health behaviors, the physical and health environment, health policy, and demographics. The intersection of conceptual clarity and evidence is when we use our conceptual framework to guide analyses that can help us identify targets for cancer prevention. In this paper, the authors propose using regression-based mediation models. Now, at their simplest level, which I'm using in the interest of time and because I am definitely not a statistician, I'm going to comment on the mediation model on the left of this figure. And I suppose I could try to do this with, I have no idea, absolutely no idea where the pointer is. So just stay with me. Look at the figure on the left. And what they say is, if the statistical association, which I believe is letter C on that figure, if the statistical association derived from the direct pathway between household income and cancer mortality is not as robust as the mediated pathway that includes the association between household income and smoking rate, and between smoking rate and cancer mortality, that means that it's important to target smoking cessation and not just income. Now, as the authors note, this can scale to models with multiple mediators. The key point is the value of this type of conceptual clarity in determining where and how to deploy prevention resources. Now, context matters not only for identifying prevention targets, but for selecting intervention approaches. So the O'Connor study was looking at the population level by county to identify and understand disparities by county in the US. We could conduct similar research at the national level, so we could be developing models that take into account type of cancer and characteristics of populations and nations by Human Development Index. Of course, the ultimate goal, repeated from the mission of the Zoo Family Center, is to ensure that all populations worldwide benefit from state-of-the-art cancer prevention strategies. And while we want all populations to benefit from state-of-the-art cancer prevention strategies, we should not blindly assume that all populations can benefit equally. In fact, one could posit that implementation of state-of-the-art cancer prevention strategies without conceptual clarity and consideration of context could increase rather than decrease cancer disparities. Now, this was reflected, I think, in some of the questions that came up this morning. Now, this is at the heart of a framework articulated by Froelich and Potvin over a decade ago. And I'm going to summarize their key points with reference to cancer prevention disparities. So as we've seen, I really do need this. Does anybody know how to use it? Is it that? Okay. Oh, perfect. Okay, thank you. I'm trainable. All right. So as we've seen, level of risk exposure is not distributed equally, okay? And that's what can contribute to cancer disparities. And this is at the heart of O'Connor and her colleagues' work that I just talked about. So here's low level of risk exposure, high level of risk exposure. The distance from here to here is your disparities. So, as I just said, the distance between high and low exposure can be a marker for disparities. Now, cancer prevention interventions that modify exposures, or risk factors, as you could call them, have the potential to reduce the burden of cancer in the population. This potential is reached when the shift in exposure moves the average exposure in a favorable direction. Now, this is at the heart of Jeff Rose's population approach to preventive medicine. And the underlying assumption is that shifts in the population mean are accompanied by gains across the entire population. Now, Froelich and Potvin challenge this in their vulnerable populations approach, which focuses on the potential iatrogenic effects of interventions that concentrate their benefits in populations with lower levels of exposure. In this instance, moving the population mean by concentrating the benefits in the part of the population with less exposure could in fact increase disparities by increasing the distance between the low and high ends of the population exposure distribution. Now, the next two slides from their paper illustrate this concept. Okay. So first, what you want to note is that this is the before the intervention curve. Okay. The distance between the right and left tails of the distribution, again, a proxy for disparities. Now, the distribution on the left shows the overall shift, an overall shift in level of exposure, okay? And the entire population shifted to the left. So there are still differences between high and low levels of exposure, but those at the lowest level improved. So they're in better shape than they were before the intervention. This next figure shows what happens to disparities when the concentration of benefits for an intervention occur in the part of the population with less risk exposure. Now, in this instance, the concentration of risks in the population with the highest risk factor doesn't change. They stay where they are. So even though this illustration shows the same mean effect as in the previous figure, the intervention elevated the risk distribution in a way that actually increased disparities. This distance got greater. Now, this is a framework, not a fact. Could it happen? At the time of the publication, the authors offered a few possible examples, two of which are relevant to cancer prevention. Cervical cancer screening that did not benefit low-income women who were less likely to be screened. And we see evidence of that today. If I showed you a heat map of cervical cancer mortality in the United States, you would see that, in fact, the heat map that showed all cancers is pretty much reproduced for cervical cancer. Educational campaigns for tobacco cessation that had greater effects on individuals with higher education. And so we're now seeing a concentration of smoking in more sociodemographically disadvantaged populations. Now, globally, this is very salient. Let's think about cervical cancer, for example. As noted earlier, cervical cancer is the most prevalent cancer in countries with a low human development index. It's also very preventable, both with regard to cervical cancer screening and HPV vaccination. However, prevention interventions that work in more developed countries, if applied in the low HDI countries, might have limited reach to the populations that need them most. This can be due to any number of contextual factors. Screening technologies that rely on adequate power and refrigeration, healthcare infrastructure, so on and so forth. Now, we can take inspiration and guidance from existing efforts that pay attention to the need to concentrate resources and efforts where the risk is highest. Now, I would refer you, for example, to a case study of a cervical cancer vaccine program in Botswana that's highlighted in the National Academy workshop proceedings. Here you'll see examples of surveillance and evidence-driven practice and assessment, cross-sector collaboration, and public-private partnerships. When we've identified cancer prevention targets that are evidence-based and mindful of disparities, we're moving into the realm of creating evidence for intervention effectiveness. And so I want to close by talking about the critical importance of the quality of the evidence base for developing and implementing effective prevention interventions. And I'm going to do this primarily through the lens of my work on the Preventive Services Task Force that now spans a decade. It was mentioned that I chair the task force. I complete my term as chair in early March. And that's like a spontaneous, I love the work, but it'll be nice to be done. So the Preventive Services Task Force is an independent panel of private sector experts in prevention and primary care. Most of you know this, but in case you don't, I'm just going to catch up. We focus on primary care feasible or feasible to refer prevention interventions for populations without signs, symptoms, or diagnoses of disease. And we cover three types of interventions that bring together the health system and the population: screening for early detection, behavioral counseling, and chemoprevention. We do not evaluate policy-level interventions or interventions delivered to individuals in non-healthcare sectors such as work sites, mass media campaigns, and so forth. However, our overarching methods and our criteria are relevant and worthy of consideration in selecting existing and developing new interventions. Because we evaluate the existing evidence base, we do not do primary research on the task force. Our methods also inform the design, implementation, and reporting of prevention research. And I can tell you that it is incredibly sobering to dive into a topic, and I'm going to repeat this a little bit later, and wade through tens of thousands of articles and come up with, as my grandmother would say, bupkis. Just a tiny number of studies, or you get a robust set of data, but you can't meta-analyze it because there's inconsistent measures and so on and so forth. So it's really been an education for me on how to make our research matter. I can't walk through all of our methods. That's easily an hour's presentation. So I'm just going to highlight a few components of our methods. And if you have questions during the question and answer period, I'm happy to answer them. Our ultimate goal is to provide a recommendation statement or multiple statements on a topic that indicates our assessment of the net benefit of a particular prevention intervention based on the existing evidence base. Now, the concept of net benefit is really, really important because you can have something that looks like it's really good at finding something, but it's also good at finding things that don't have any implications for health. And then when you find those things, there's a protocol that people fall into that have some pretty serious invasive procedures and so on and so forth. So we have to take all of those things into account. Our assessment of the existing evidence is guided by an analytic framework and an accompanying set of key questions that the framework articulates. This framework takes into account benefits and harms, any special populations, sometimes guided by knowledge of disparities or the biological basis of the disease, intermediate and direct health outcomes. Now, this is our generic framework for evaluating a screening intervention. And again, I'm not going to do a deep dive into this, but I think it's important to know it if you're going to be designing studies that you want to be able to be used for determining whether one should recommend a screening test. So the framework guides us to ask questions about whether the recommendation focuses on the general population or persons at greatest risk. The reliability of the screening tests, and we've heard a lot about both sensitivity and specificity. The impact of treatments or other sequelae of early detection on intermediate outcomes. The impact of screening directly on health outcomes. The association between changes in intermediate outcomes and health outcomes. That's that dotted line, and I can tell you, I wish it didn't have to be dotted. That's a big challenge, filling in that dotted line. The incidence and severity of any adverse effects of screening or treatment following a positive screen. So working from the analytic framework and the key questions, the task force, along with evidence-based practice centers that conduct our evidence reviews, articulate the types of studies that we're looking for to answer our key questions. And this look at evidence is guided by PCOTS, which is who's the population, what are the interventions that we're looking for, what is the comparator. We do not evaluate comparative effectiveness studies. We look primarily for randomized controlled trials with usual care as a comparator. What is the outcome? What's the timing? How long is the follow-up? And what's the setting? Is it primary care feasible or feasible to refer? And for each of these categories, we specify both inclusion and exclusion criteria. And I have to say, when Rebecca was presenting and she talked about the, if I can read my writing here, the clinical infrastructure for research and early detection, I wrote wonderful in my notes because people can come to a place like that and get guidance on designing your studies so that they actually wind up in an aggregate look like we have in the task force. So once we have a synthesis of the research that met our inclusion and exclusion criteria as it relates to each key question, we then have to determine the strength of the evidence and the certainty the strength of the evidence for benefits and harms and the level of certainty with that evidence. These two key factors determine the summary or letter grade recommendation that the task force gives, and this is the grid that we use. If we have high certainty of a substantial net benefit, that gets an A. If we have high certainty of a moderate benefit or moderate certainty of at least of a high benefit, this gets really, we have this thing up all over the room when we're deliberating because you just spiral into a rabbit hole. But you get a B grade. High or moderate certainty of a small net benefit results in a C grade. High or moderate certainty of zero or negative net benefit is a D grade. And low certainty related to any net benefit results in an I grade. And the I got lost in the background. That for some reason, the task force slide has it as white. But that would be an I, which simply means insufficient evidence. So I'll give you an example. We had, I'm sure, there's always been a big hoo-ha about this, a D grade for PSA screening for prostate cancer. We update and that was based on an assessment of either a zero or a negative net benefit for people without signs or symptoms. And that was based on a number of randomized trials and so on and so forth. We update our recommendations every 5 years. We just updated that recommendation, and it is no longer a D recommendation, it is a C recommendation, which is a shared decision making. Now, the data that we had that allowed us to get off of a D to a C had two parts to it. One was there was longer follow-up in the randomized trials that informed the earlier recommendations that showed a movement towards some modest benefit, small benefit. And secondly, there was a movement in what you did when you had a positive PSA in terms of moving to active surveillance rather than going straight into aggressive treatments that often have some pretty negative sequelae. So, when the practice paradigm changes and the data is enriched, you can see that reflected in what the task force determines is the level of certainty and the size of the net benefit. Now, as a brief aside, I just wanted to show you something from a more global perspective. The International Agency on Research on Cancer, or IARC, they have recently reestablished their handbook series. This is an example of a recent one. Actually, Graham chaired the committee that put this together on excess body fat. It looks primarily at epidemiologic data to determine the cancer prevention potential of an intervention, which I would argue is not the same as evaluating the intervention itself. And it has a similar grading system, not identical. So they give an A grade if it prevents cancer, a B if it either probably or possibly prevents cancer. Unclassifiable is a C, and probably does not prevent cancer is a D. So I want to make a few concluding remarks about research and then wrap up my overall comments. So what I've observed in my service on the task force is the need for better alignment of research priorities and research investments. And this isn't just about investing more money, although we need it. Only about 5 cents of every federal research dollar is invested in prevention research. And that's even though the majority of our healthcare expenditures are spent on preventable diseases, including many cancers. Going forward, we should be focused on conducting research of sufficient quality and not just focus on quantity, on the number of available studies. In an average evidence review for the Preventive Services Task Force, even reviews where we land on an I for insufficient evidence, we examine upwards of 10,000 citations. We review over 400 full-text articles, only to get anywhere from 3 to 8 studies for a key question. And in truth, we often have 0 studies linking directly to health outcomes. We usually have to follow the indirect path. We need more collaboration and cross-fertilization in our research enterprise to assure that studies are conducted with the appropriate rigor, applicability to the real world, easy aggregation of data, common measures, common language to describe intervention components, and assessment and attention to assessing both benefits and harms, as well as attention to creating evidence that allows us to link intermediate and health outcomes. We've sometimes been able to get to a B or even an A recommendation based on robust cohort studies that allow us to fill in that dotted line between intermediate outcomes and health outcomes. And so the kinds of studies that can inform that part of the analytic framework are not limited to randomized controlled trials. We need more diverse populations in our studies, and we need more diverse settings in which these studies are done. And finally, we need more dissemination science. The task force has 19 active cancer-related recommendations, and only 2 of them had overall insufficient evidence. Now, a few others have some insufficient evidence for 1 or 2 subpopulations, but even with robust evidence, the challenge we have is building the bridge from what we know to what we do. So by way of teeing up some of the next speakers, I'm going to close by sharing the following. I've mentioned Jeff Rose, who first published his book on preventive medicine in 1992. I don't know if anybody here read that book? Okay. It's an amazing, thank you, extra points in the back. It is an amazing book, and it actually, was where he introduced the population perspective, and he talked a lot about the potential limitations of the population at risk perspective. Now, he used cardiovascular disease, and I'm not going to go into all the details, but the take-home message was, if we had a 100% success rate in preventing MIs in the populations that either had early disease or known risk factors, the best we could do is prevent 30% of all of the MIs. And I think we run into a very similar, and that just has to do with the majority of, maybe we need to know more about risk factors. Maybe, our toilets will tell us at some point. But I think the point that we need to be mindful of is that a lot of the risk is just, is not a lot of the disease is not concentrated in the folks with the highest risk. And so that's something to think about. And then, as I said earlier, Froelich and Potvin noted that you have to think about the vulnerable populations approach in addition to that. So they proposed that as an alternative to the population perspective. Anyway, I do go on. But in the first edition of Jeff Rose's book, and you've probably all read this by now, he said something that really struck me because I read this back in the 90s, and that was the knowledge that we already possess is sufficient if put into practice to achieve great health gains for all and to reduce our scandalous international and national inequalities in health. That's in 1992. It is 2019, and we're still there. A decade later, I had the honor of co-editing a report from the National Cancer Policy Board of the Institute of Medicine. Wonder where that title came from. Fulfilling the Potential of Cancer Prevention and Early Detection. And this is how this report starts. It says, imagine opening your morning paper and seeing the headline, Interventions Succeed in Preventing 100,000 Cancer Cases and 60,000 cancer deaths each year. Reading further, you learn not only that lives have been saved from cancer, but also that remarkable gains have been made in reducing heart disease, diabetes, and other major health threats. Such a promising headline is within reach because prevention interventions are available today, 16 years ago, that can sharply reduce the future burden of cancer and at the same time reduce the risk for other chronic diseases. And I just want to add a point, which is I was really intrigued by this concept of passive sensing and like people didn't have to actively do things in order to identify their risk. Well, we have some tremendous opportunities for passive cancer prevention. We can improve the quality of our food. We can improve the quality of our built environments. We can improve, our insurance coverage so that people don't pay for prevention. I've seen it even in my own demographic. And so I just want us to be mindful of that. Now, we never want to stop discovering and building the evidence base for effective cancer prevention. But that evidence base needs to be mindful of areas of greatest need and potential, which means we must address disparities and develop and evaluate interventions that are feasible in the populations and settings where they are likely to have the greatest impact. We must have a pipeline of outstanding cancer prevention scientists, as this work will continue past our shelf life. We must partner within and outside of the academic enterprise, and we must focus on science and practice that helps us build a strong bridge from what we know to what we do. In short, we need organizations like the Zoo Family Institute for Global Cancer Prevention. And so with that, I say thank you for your attention, and I look forward to our next speakers.